Okay, so for this lecture, we're going to discuss medical conditions and how they're kind of related to the underlying pathophysiologies or the causes of disruption of people's physiology. Now, unfortunately, we're going to focus only, or we only get to focus on the cardiovascular pathologies of medical conditions that are very common. In addition to that, it's going to be a fairly quick overview, but I definitely encourage you to spend a little bit more time to get a deeper understanding of each of these to broaden your knowledge base of these. But what my hopes is that I give you just a general understanding of what's going on as far as its pathology or pathophysiology and go from there, okay? So we're going to start off, though. If we were to start anyone's exercise training program, of course, we need to get medical clearance. And the reasons for this are largely around screening for cardiovascular risks and other contraindications. So things that we would see that would make us say, no, we want to stop, or we don't want to have this person exercising, okay? It's also helpful for us to determine maybe certain motives that our person has to help them increase their adherence to their exercise or health program, because we can see where they might recognize they have shortcomings as far as their health or performance and be able to improve that and use that as a motivator. Okay, so at some point in time, perhaps you will come across someone that doesn't quite meet your requirements for medical clearance, and thus we need to send them to get a medical evaluation. Now, how do we know how to do this? There's a number of ways. We're most familiar with PAR-Q, but there are some other ways to go about this. And occasionally you'll get someone that generally even looks healthy, but we'll need to go get PAR-Q. So don't make an assumption just based off of how someone looks for sure. But generally speaking, if someone, for all intents and purposes, based off of their surveys or their questionnaires that they fill out and hand back to you, you can generally start slow and low, as the saying is, low to moderate, and won't need much medical evaluation. If for some reason something comes up, so for example, we issue one of these AHA or ACSM questionnaires, and some risk factors come up, then you need to send for medical clearance. And one example here of a intake form or medical clearance type risk factor survey to fill out would be something like this. So the medical history, some symptoms, other issues, and cardiovascular health risks. And then here are some instructions, as some of you would have done on if you created your own intake forms and included these. That was great. So again, telling you some direction, what would happen if you checked off a certain amount of those values. Here we have again, just a kind of a rundown of risk factors for CAD. So CAD is cardio arterial disease, and just looking for any predisposing factors where you'd need medical clearance. So if someone's a bit older, for men over the age of 45, women 55, a history of medical or coronary artery disease or cardiovascular disease from any of their first degree relatives, so like one relative away, so their parents and or even aunts and uncles. Smoking, physical inactivity, again, sitting for long periods of a day will be a risk factor. Hypertension, we'll speak to what that is a bit later. Dyslipidemia, sorry. So that's again, we'll talk about cholesterol profiles a bit later. Diabetes and obesity, all these have certain requirements and guidelines that we would look that would be present, say, with some sort of stratification here on our intake forms for reference. So wouldn't have to memorize that. Okay, but if we do need to send someone to get checked out before they get medical clearance for beginning an exercise program, again, this is just to try to screen for that. What will happen is they'll go in for an ECG, most likely, if the physician also feels that they need some more medical clearance. Perhaps blood pressure wasn't good, and they just want to make sure everything's working well for their heart. They might send them for one of these. And again, we've been over this a couple of times. The setup, if you recall, we'll get to see that in a moment, is on a treadmill typically, and you have these electrodes attached to you for our electrocardiography, ECG. And here we have a couple of exercise physiologists and maybe a nurse or lab tech on hand here, ensuring that this person is okay during their stress test. And so during a stress test, what they do on a treadmill is slowly and incrementally increase both the incline and the speed of the treadmill until we get to volitional ending typically, but they will watch the ECG while the person's performing their stress test, and will stop it and end the test if need be. What they're looking for is something like this. So the height, or the y-axis, is the amplitude or amount of electrical activity being read. The x-axis on here is time or duration in milliseconds, and what we'll see with our ECG is a little wave initially. If you recall, that's atrial contraction. So the two, if you remember the heart chambers, the top of the heart chambers, the atria. So we get contraction there, and that's our R interval, or our P wave, as we could call it. So it happens during the R to R interval. We have our QRS wave, and that represents ventricular contraction. And if you remember, the largest part of our heart contracting, thus we see a lot of electrical activity during all that nerve activity and conduction. And then we have our ST segment here, which should generally be flat and level, and our T wave at the end. So that's our ventricular relaxation. So again, because we have so much cardiac muscle there relaxing, it also repolarizes, and we see that artifact or that wave on our ECG. Okay. Yes, when we see differences there with our graded exercise tests, we can see anything from arrhythmias, so we'll see erratic, typically our QRS waves, but depending on what's happening with the heart, maybe the atria or different valves, we'll see different artifacts on other aspects of the ECG. For our ST segment depression, that was that flat wave after our QRST, so right here, ST segment. So what can happen is that's low. If that's the case, typically we have insufficient blood supply to cardiac tissue, and we'll say what that looks like. We discuss some of our medical conditions later. Normally we want our blood pressure to increase, but sometimes we'll see some abnormally high indications of that during our graded increase of exercise. And a lot of signs and symptoms, a lot of these leading to the end of our stress test, would be things such as shortness of breath excessively, dizziness, angina, which is pain, chest pain, pain in the neck, jaw, or forearms. They all end the test. And just to keep note that coronary artery disease, and remember, the coronary arteries are the arteries on the heart itself that serves blood to the heart, will only identify about 66% of individuals. However, that is a very good source of measure for other conditions of the heart and other forms of cardiovascular disease. And it's not recommended for beginning exercise in men over 45 or women over 55, except when high risk for disease. Okay? So again, when there's really, really high risk, we don't want them starting to exercise. Okay, So let's say we got our medical clearance, we're good to go. Our individual might be at risk for cardiovascular disease, but it is important for them to start exercising because, as we know, exercise will help prevent cardiovascular disease or help mitigate it or fix it in some cases. So when we look at CVD or cardiovascular disease, we get to see that over the past, since the 1970s, we've had a steady decrease in deaths from cardiovascular disease. One of the reasons is we live in, quote unquote, the golden age of cardiovascular medicine. And because of this and major progressions of medical advances for heart disease, actually going back to even the late 1950s, with things such as stents and pacemakers and imaging techniques that allow us to see the heart better, catheter surgeries, etc. We've decreased the amount of death from about 50%. If you had cardiovascular disease, you had to flip of a coin if you're going to continue living, to about a third of that. And in particular, again, those advances in medical techniques and diagnosing as well as treatments is great. Bypass surgery, for sure, a good example of that. But also, ongoing management of disease through drugs is helpful, but a greater knowledge of lifestyle changes. So exercise being a good way to help, a lack of exercise being a lifestyle change that would increase your risk of cardiovascular disease. And so by using changes in lifestyle for individuals, we've managed to help to some degree for some people decrease and manage cardiovascular disease. Okay. If we look at the US of A and some stats from them, we can see that cardiovascular disease and other cardiovascular diseases, not just coronary heart disease, but a lot of cardiovascular disease has So if we take a peek here at all of the cardiovascular disease that we can find or that we have in the US, by percentage, coronary heart disease is one of the major causes. Stroke, followed by stroke, high blood pressure or hypertension, and heart failure are some of the major ones, others less so. And even though we have so many advances in our medical treatments and decrease in mortality rates since the 1970s, cardiovascular disease is still one of the major leading causes, right up there with, or causes of death, right up there with cancer still, last I checked. So again, some of this might seem a little fast. Please feel free to dive back into some of these and know them at greater detail. I think all of this is really, really interesting. But again, I'll just aim to give you a general idea of what's going on. So with coronary artery disease, again, our coronary arteries are the blood vessels on our heart that serve oxygenated blood to the heart so it can keep pumping, and it accounts for about 50% of all cardiovascular problems. Ischemia is this term where there's insufficient blood getting to tissues downstream from whatever blood vessel is serving those tissues, and typically we'll see it's a partial blockage. Now we'll see aggravation of this ischemic tissue or lack of oxygenated tissue when we do things such as exercise or stress. One of the highest rates of heart attacks, just as a side note, typically occurs during Super Bowl, so very and this is in the States, so during high stressful events. And that's when a first myocardial infarction or heart attack can occur. And you can have these TIAs or partial heart attacks where you have some ischemic attack, but where you get some chest pain or angina pectoris, but not a total heart attack or total oxygen deprivation of the heart muscle or cardiac muscle itself. Okay. Now, what kind of causes some of this ischemia or artery disease? Well, this idea of athero and arteriosclerosis, so a narrowing and eventual thickening and loss of the elasticity of arterial walls, and that can also lead to a thrombus, which is a blood clot, and all of that can cause, or is part of coronary artery disease that can lead to an MI or a myocardial infarction. Okay, so if we have our normal artery that looks something like this, usually there's a couple of different mechanisms, but one of the ones that I think is best supported now is you can get a little nick in the arterial wall. You get a bit of an inflammation response occurring. So you get like white blood cells, and ultimately the main issue, fatty plaques building. So what happens is fatty plaques build because fat gets and cholesterol gets attached to this inflammatory process, which kind of layers up this plaque, which is kind of soft but has hardened layers depending on what's going on. And it becomes this process that just continues to build up. And as the plaque thickens, the place where blood can flow through narrows. And so, for example, you can have a almost full clot, and again, that causes ischemia or lack of oxygenated blood getting to tissues downstream from that. What can also happen is part of this plaque can break off and becomes embolotic or a thrombus. So it kind of breaks off and flows down into a more narrow artery or capillary bed and causes some blockage there. So things to certainly be aware of that can arise from coronary artery disease and this atherosclerotic thickening or hardening of the walls that become arteriosclerotic. Okay. Here's just again a little reminder where you can see our coronary arteries, and if we have a blockage here, for example, the tissue downstream being served from that artery will lack oxygen, potentially completely dying, or if nothing else, causing significant pain and discomfort. So a stroke, so we were talking about the heart. Now the blood supply to the brain is typically what occurs in a stroke. There's a couple of different mechanisms where this happens. One is an ischemic stroke. So what will happen is blood flow or blockages in the vessels. Again, as I mentioned, due to like a thrombus or an emboli from another part of the body, will find its way in and end up in the blood vessels serving the brain. And when that happens, again, a lack of oxygen causes brain tissue to die. The other way that can happen is through hemorrhage or a rupture of some of the blood vessels. That can happen again because of that plaquey buildup on the walls of arteries, causing them to be weak because they're strained because of this plaque. You can also just get hypertension, causing some strain on vessels and eventually wearing them down. And that can be right on that can occur in a vessel that's directly serving your cerebral cortex or like the brain tissue itself. Or what can happen in a stroke is this these wrapping or sheaths around the brain can hemorrhage. Of course, the vessels that they serve Downstream will also die, but you'll also get pressure building up intracranially, so within your skull. That can also lead to some pressure and therefore brain trauma. Now, depending on where a stroke occurs and which vessels are affected, will change how the outcome is for the individual. So, for example, if your motor cortex gets primarily injured or has a stroke occur there, your motor movements or volitional or voluntary movement can get affected. If your speech center ends up getting affected by a stroke, your speech will go and change to varying degrees, again, depending on where in the brain stroke occurs. Okay. Heart failure sounds very dramatic. It is different than a myocardial infarction or a heart attack. What typically happens here is your ventricles or the ventricular contraction becomes impaired, either due to scar tissue or pharmacologically getting impaired. There's a number of different things, but the ultimate thing is our cardiac output is insufficient. Okay, so coronary artery blockage, drugs or toxic substances, hypertension, lots of TIAs or mini heart attacks occur. A viral infection, as we definitely know from COVID, can also lead to heart failure. And again, heart failure is that decreased cardiac output. So if we think of our ventricles not being able to contract very much anymore, what needs to happen is some compensatory mechanisms. So for example, if our stroke volume has decreased because of damage to the ventricles, our kidneys will start retaining fluid to try to bolster our blood pressure, right? So if our blood volume is going up, that will help keep maximal fluid and pressure moving, even for minimal contractions. But that puts a lot of strain on the body and the arterioles, and essentially you get a lot of fluid buildup intracellularly or in different areas of our body, and the interstitial fluid, because the heart or the kidneys are just keeping that blood pressure so high, just to try to keep blood circulating your body. So again, we have ventricular hypertrophy occurring because even though the ventricles aren't able to contract much, they still want to try to build up some muscle. We've got our very high blood pressure and our fluid accumulating both in the lungs and where gravity pulls all fluid in our body. If we're standing a lot or sitting a lot, into our ankles and legs. So again, it gets increasingly worse over time. Related but slightly different. So again, chronic heart failure is the ventricles having issues, not being able to pump blood much. So therefore we get high blood pressure. Hypertension is high blood pressure. And so that's chronically so. At rest, again, if we start working out, of course we want our blood pressure to come up. And that's anything over 130, over 80 millimeters of mercury. So the heart must work harder to pump because there's so much residual resistance because of that high blood pressure in our bodies. And because of that, because we're trying to get blood moving, but there's all that peripheral resistance of fluid, again, we just have a higher oxygen demand with that higher workload for the heart. We have lots of strain on the arteries, increased chance of stroke and other issues. But one of the correlates, other issues, other cardiovascular disease, one of the main correlates or correlational factors to hypertension is obesity. So children and young adolescents and toddlers, they have low blood pressure, and the reason for that is because they're smaller individuals. But once you have a lot of mass on you, let's say a lot of adipose tissue, that weight pulls onto your body, and you need to be able to pump blood around. So you have this correlate against that peripheral mechanical pressure to get blood around. and it's associated with obesity. Increases work, oxygen needs. So I think we spoke about that. As we exercise, we get more. There's a higher oxygen demand, which increases that blood pressure additionally. So if individuals are about to work out and they're hypertensive, you just need to be very mindful of that and start with very low intensity exercises to not exacerbate the hypertension. And of course our risk of heart attack. So what exactly is good blood pressure? You all know how to take blood pressure, right? So what are you looking for? Well, again, anything over 120 is concerning, again, on the systolic side of things. But as soon as we get to over 80, closer to 90 for stage 1 hypertension for our diastolic, that's a big indicator. Anything over 90 for diastolic blood pressure is certainly something that you want to go get checked out for ensuring to see what is going on as far as causing that hypertension in you, in stage 2 in particular. Okay, great. Risks for hypertension, a lot of it has an unknown cause, so that's called an idiopathic cause. So, but there's many risk factors that all contribute to this. Physical inactivity, obesity and overweight. Unfortunately, there is a large genetic component as well. If you're male, increasing age, so the older you get, you're more at risk. If you have sodium sensitivity, which not all individuals will, but as part lifestyle stuff such as tobacco or alcohol consumption, stress is definitely part of it. Diabetes, oral contraceptives, so birth control, depending on which you use, there's a risk factor for that. And pregnancy, there's a certain type of hypertension that's unique and specific to pregnancy, and you definitely want to keep an eye on that. So again, the other way to look at this too is the more of these that you would potentially check off as things that are part of your life would increase the risk factors for hypertension. So you're more likely to have it. So if you have a client or someone come in to see you with many of these, then definitely probably an exercise program is helpful for them. But also you need to consider all of that for hypertension and when you start programming their exercise for them. So peripheral artery disease, we've spoken about in a way. So it is the atherosclerotic progression of our vascular system outside of our coronary arteries. So again, CAD is specific to the heart, periphery or PAD is the periphery of our body. And we already spoke about the mechanism of how atherosclerosis or those fatty plaques can change or reduce blood flow in the area or cause problems in other areas. Typically the way that you'll figure out you have some sort of peripheral artery disease will be from this claudication. And again, that's when you start exercising, you get very sore limbs, such as arms or legs, or both as you continue on. Okay. The major risk for this, typically, again, increased age, so older than 65 in this particular case, being male. Some research says there's some indication that menopause might be a cause of this. And last but not least, it is certainly potentially, it is genetic or hereditary. So any other cardiovascular disease definitely puts you at risk. Some other major contributing factors include smoking, blood lipid profile being high. We're going to discuss what that is shortly. If you're hypertensive, obese, have diabetes, or inactive. Again, minor ones are psychological stress, alcohol, diet, and nutrition, which I think they find are more, controllable versus, say, our previous factors here, which are uncontrollable. Okay. Yeah, here's some actual specific guidelines. This would just be a reference you could look up if you ever actually got any of this information, such as some of this blood testing. But obesity rates or obesity measures as far as BMI. You could always come back and take a peek at your reference material, working with individuals in the general population. But I wanted to speak in brief to blood lipid profiles, in particular LDL or low density lipoprotein cholesterols and HDLs or high density lipid protein cholesterols, because you've probably come across these in your day-to-day life or just hearing articles about nutrition, for example. So lipoproteins are these clusters of lipids and proteins that get are like carrier molecules or like Ubers for lipids in our body. So our fat doesn't typically want to be in our blood because it's water-based, and fats are fat-based or oil. So water and oil doesn't mix, so they need some special form of carrier to take them into the blood, or take fat into blood for us. And so when we see these lipids in blood, we have these lipoproteins associated with them. Now, there's two types. There's LDL or lousy or low density lipoproteins, and they're produced by the liver to transport cholesterol around and triglycerides. So it takes it to the body tissues. High density lipoproteins or LDLs transport lipids from the body tissues to the liver for storage. Now, if we had a lot of LDLs, that means we have a lot of fat in our blood that are going to our body tissues. Okay, and if that proportionately as a ratio is much higher than our HDLs, it means our liver isn't essentially taking and storing some of this fat. So now we have both in our blood. We need both, right? Because one's transporting one direction, one's transporting the other. But typically when we're looking at disease or dyslipidemia, we want that's usually a case where we have a high number of LDL and a low number of HDL relative to one another, and that usually leads to higher risk of coronary artery disease. Okay, so ideally when we're looking at our cholesterol levels, we want to see our HDL in a good level. Okay, if we look back here's our HDL and LDLs. So again, if we want it under 40 here and under 160 here for our LDLs. Okay, that's all. I'll speak to that, sorry. Okay, so moving forward, obesity and overweightness, as we have previously spoken about, and we can see a bit of an older stat here from 10 years ago, or over 10, is about a third of adults are considered overweight, and 30% of those are considered obese. So yes, it's true, the BMI does not consider body composition, and even truer in particular for more people with athletic builds, but it is still typically not too far off when we're applying this to the general population. Okay, that excess body fat, as we notice from it can increase our chance of heart attack or stroke. Okay, the extra work from having to carry around the extra mass that is not lean muscle tends to increase the heart's work and blood pressure, increase cholesterol, decreases our HDL, which we want more of, and try to keep those numbers within range but high. And it predisposes us to diabetes because we end up going through this metabolic change in our body, which we previously spoke about in our hormonal system discussion. But ultimately, we have two types of diabetes. If you don't recall, diabetes is our pancreas and body trying to manage our blood sugar levels. Okay. Now, type 1 is typically, well, it's a failure of the pancreas to produce insulin altogether. Usually that's right from birth, but there are exceptions to that, and type 2 is a result of insulin resistance. So this typically is the more common one that we will see with obesity rates, is type 2. And essentially the body becomes resistant to the insulin that is produced, and we have to mitigate that. Luckily, aerobic and resistance training both help increase insulin sensitivity and is recommended to help regulate our blood sugar levels. And last but not least on this lecture, physical inactivity will have the opposite effect of being physically active, in the sense that we will see just that it's a major risk factor as a lifestyle factor to this. So physical activity decreases our coronary artery disease due to positive physiological adaptations. So it helps prevent the onset and severity of coronary artery diseases. So both aerobic and resistance exercise helps, but when we're talking about cardiovascular risk in general, aerobic is the go-to. As you recall, resistance training just has a little bit of cardiac heart changes, so it just increases our ventricles and capacity to overcome external resistance a little bit. Whereas aerobic training has a lot of changes on our cardiovascular system, everything from increasing red blood cells to lower heart rate or more efficient heart rate, or I guess even more so, more efficient cardiac output. And that's definitely beneficial to helping avoid this. Decreases blood pressure, and with our increased body composition, we also decrease the chances of developing diabetes and therefore insulin sensitivity. Okay, it was a little bit of a whirlwind, but there was lots to cover, and again, the goal was to get a broad recognition and understanding of some of these cardiovascular diseases for your knowledge, should they ever come up and present themselves for clients that you're working with, or potentially even yourself. Okay? All right, thanks.